okay? Now, this patient, when it comes to this awful situation, the chest tube, I gave you a nice handout. I don't know if it's on the next page. Couple pages in, I gave you the holy hookup. And it says chest tubes right on it. Couple pages after that. Yep, there you go, boom. Everything that could ever be a question on anyone's test in the world is on this sheet. But I want you to put at the top, because I somehow remember it, I don't know why, but I want you to put at the top, if the chest tube disconnects from the system, the actual container itself, if the chest tube disconnects from the actual container itself, you're going to place the end of that tube in sterile water or saline. Notice the emphasis on sterile. So if the chest tube apparatus comes disconnected, the tubing pulls from it, oh, let me tell you, your students, they're going to disconnect your shit by stepping on it. They don't even be looking where they're going. And so they go on leaning over to listen to the patient's lungs and pop my shit off. So if it comes disconnected from the chest tube apparatus, then you're going to go ahead and you're going to make sure you just hurry up and put the damn thing in water or saline sterile, because you can't have this open. This is a closed system. Now, what if it disconnects from the patient? All hell gonna break loose. And that happened, the other young lady told me it happened to her patient in clinical. So put if the tube disconnects from the patient, you're going to use a Vaseline, well, let me back it up, sterile Vaseline occlusive dressing, sterile Vaseline occlusive dressing to the site. Because what if air gets in there? Air embolism, yep, it's so ugly. And shit just be happening, big time. So now if you look at the chest tubes themselves, let's look at some things that'll make sense if I play it out for you. Let's say you have a cabbage returning. Well, you wouldn't, but because unless you work in the unit, like very few people do. But let's say that let's be more realistic. Let's say you had a patient with lung cancer. That's what we'll do. You have a patient with lung cancer. One of the most common things a patient comes in with lung cancer is a pleural effusion. A pleural effusion, for shits, kicks, and giggles, is a bunch of damn water in the lungs with the cancer around it. The water is around the cancer itself. So let's say that the patient came in like that, like my papa. Okay, so we're gonna drain him doing a thoracentesis, but then the doctor wants to insert the chest tubes. Now, when he inserts the chest tubes, we're going to connect the chest tube to the wall suction. This is not your damn patient, this is the wall. That's important, because for the wall suction, you should have continuous bubbles. Emphasis on continuous. So you better highlight that shit. Notice I wrote that they should be gentle. What you don't want is vigorous, because then you're going to have to turn the suction down. You're doing too damn much, okay? Okay, now water sealed chamber, that would be your apparatus on the floor. With the water sealed chamber, you have to literally quote me on this. You have some words there. They say intermittent, fluctuating, and periodic. Does everyone see those words? Now that's describing when you would see bubbles. It wouldn't be continuous like the suction on the wall. If it was, your patient dead. But if you're talking about the patient, which I told you the water seal chamber is your patient, you should not be having continuous bubbles, because bubbles are only seen on expiration. Although you have to write another word down that you have to quote, and that would be titling. Titling is seen with inspiration. Think of it like this. A tidal rises. And when I inspire or inhale, my chest rises. So, and that's the tidal. The tidal goes up with your chest wall. Okay, so it's going up when you go up. Okay, so tidling with respirations, which in particular, inhalation. Okay, that's important. Then you're going to want to know that this should never be cloudy. Under number 4, you'll see a bunch of things that says shouldn't be cloudy, shouldn't be red and free flowing. And then it says don't empty the damn thing. You cannot empty this. Only thing you can do every shift is take your little black Sharpie, draw a line on it, initial date and time it, boom, every 8 hours. You try to empty this, you just opened up a closed system. The purpose of the chest tube is to keep this negative pressure. I want you to pay attention to the 3rd bullet point under number 4. Remember that if you don't have any bubbling, if you don't have any tidling, if you don't have any drainage, it's time for the damn thing to come out. The lungs have healed. Okay, so the lungs have healed. You might want to know this on top of that sheet. If you turn the page, the next one says bronchoscopy, and we're going to put this with it. Bronchoscopy, medial stinoscopy, thoracentesis. Now, a bronchoscopy is an oscopy procedure, and you see that the patient's position is sitting up. We are trying to diagnose, because every time you see the word oscopy, usually there is a biopsy of some sort. In this case, we are trying to diagnose lung cancer or sarcoidosis. So we're literally trying to diagnose lung cancer or sarcoidosis. We're looking at the larynx. We're looking at the trachea. And of course, no brainer here, we're looking at the bronchi. So we're looking at the larynx, which is your voice box, the trachea, and the bronchi. We're looking at all 3 of those structures. We're doing a biopsy if we have to. The patient is sitting up. You have to take out their dentures and their contact lenses. Pre-op medications before any procedure include your benzodiazepines. Quote me. Pre-op medications before any procedure are benzodiazepines. You have to make sure the patient is awake but gently sedated if it's going to be a flexible scan. If it's a rigid scope, they're going to be put to sleep. Now, one of the reasons we want to sedate them as much as we can is because we want to depress their vagus nerve. We want to depress their vagus nerve. You keep this patient NPO until the return of the gag reflex. Keep the patient NPO until the gag reflex returns. Gag reflex usually returns within an hour. Sometimes if you look at the bubble that's on the page itself, it's called a multitude of things. It says, report any breathing difficulty. Next to that word, breathing difficulty, put stridor. Stridor. So report any breathing difficulty after the test. Check the gag, the cough, and the swallow. Those are all the same thing. Gag, cough, swallow reflexes are all the same thing before food. And the patient was NPO. That was something that you had to quote me on. The patient was NPO 4 to 8 hours before the procedure. Okay. Now, a mediastinoscopy, which is on the board, a mediastinoscopy is done in a similar fashion, but it's taking an actual biopsy underneath the sternum. So that's the difference, that it's taking a biopsy of the suprasternal notch, because what aligns the sternum is lymph nodes. Those little balls on your textbook, lymph nodes. When we do a mediastinoscopy, we're checking for sarcoidosis, and we're trying to stage cancer. This could be a general if the tube is rigid, if the scope is rigid. Okay, now, thoracentesis, what you had to know about a thoracentesis is that your patient is in a chair or on the side of the bed, and they're leaning over a tray table just like this. I put a pillow down because I want my patient comfortable. So you know the tray table. Put a pillow on top of it, have your patient lean over it just like that. So they're sitting up, almost like tripod position. And we generally go back up in here where we try to get over wherever it's the most fluid. So we come from the back side a little bit over in the flank area. And you can take 1 to 2 liters off. You have to be careful when you get to 1 liter, because you just decrease the volume to such an extent that you could have hypotension. Because what controls blood pressure? Volume. So you could have a patient who crashes because you took too much fluid off. Now that fluid gets sent off to the lab. It gets sent off to be tested, and I can tell cancer through the pathology report from the fluid. My papa's cancer and everything else could be staged off of the fluid. Okay, so this is a thoracentesis. Now, don't forget the position. Don't forget why we did it. We didn't do it for diagnostic purposes, but we can send it off to be diagnosed and analyzed. We actually did it so the damn patient could breathe. You can't breathe with this pleural effusion. So pleural effusion is one of the #1 reasons to do it. It's going to prevent the patient from breathing normally and pain-free. Lung cancer is the #1 person I've ever seen get a thoracentesis. And it's because when they have lung cancer, they develop so much fluid, they can't breathe. Ironically, I have 2 papas with lung cancer. One never smoked a day in his life. It was mesothelioma. And it came from being a plumber at Ford for 35 years. But that mesothelioma, which will probably make your test, if it's a good test anyway. Mesothelioma, non-smoking lung cancer caused by asbestos. Asbestos, so environmental contaminant.